Welcome to the Thyroid Fixer podcast, where I'm all about helping you lose that stubborn weight that won't come off no matter what you do. Get off your couch at 2 p.m. and get through your day with energy and stop counting the hairs that come out of your head. I'm your host, Dr. Amy, and I'm here to help you get optimized with your thyroid and your hormones. It's all part of living our mantra: better thyroid, better hormones equals a better life. So let's get you back to being the badass human that you're meant to be. Let's approach it from a thyroid and hormone optimization standpoint. Between myself and my guests, you will be loaded down with information to take control of your health and get back to being you. So let's get started. You know, I'm so passionate about giving you information that you can implement to actually change your life, change your body, fix your thyroid, fix your hormones. So that is why I am doing, for the first time ever, a Fix Your Thyroid Masterclass. Time to break free from the fatigue and the fat that we're dealing with and that we're so frustrated with. So I want you to attend live. I want you to be there live. We are going to go over so many things. The TSH trap, what doctors should test and they don't test, even integrative and functional practitioners, how they're treating or how they're scamming you, these thyroid detoxes out there, what supplements you really should be using. We're going to give you real answers, and we're going to end with a live Q&A with me. So that's why you have to be there live. We are doing this in September. So click the link below. It'll have all of the information, the dates, the times, the sign up info. Go to fixyourthyroid.com and you'll find it there. You'll find the details. I want you there. I want you signed up. I want to see you in the meeting. And I want you asking your questions and taking notes. Let's do this together to get you to the next level. Fixyourthyroid.com. So I'm at a conference, standing on my feet all day long, in heels, on concrete, talking to people. I'm exhausted. So I decided to take a little walk around this conference. And I find this company, Align. They have these mats out on massage tables. And I start talking to them. I'm like, what are these mats? You know, I've heard of PMF and all of that. She's like, no. These mats are going to actually shift your nervous system. I was like, well, that's great, because right now I'm wigged out, stressed out. I'm exhausted. My back hurts, my feet hurt, my legs hurt, everything hurts. I can't focus anymore. I can't hold another conversation. She's like, go ahead and lay down. So I lay down and I figure, you know, if anything, I'm just going to doze off maybe for a little bit. But I kid you not, 15 maybe it was 10. I don't know. Time flew. 10, 15 minutes later, I get up and I just start laughing. I'm like, wait a minute. I feel completely different. Like I feel like I just got 8 hours of sleep. What's going on? And she's laughing and she's explaining this Align mat. And that's exactly what it does, is it realigns you. So the technology in this mat is like nothing else you will find. It uses infrared heat. It helps to relax the tissues. It promotes actually cellular detoxification. So that's cool. We're clearing out our cells. EMF free, totally easy. You just throw it on your bed, on the floor, whatever you want to do. You can adjust the heat. You can adjust the frequencies based on what you need. But anything from calming the mind to improving your mental clarity and cognition, that's what I needed. I needed to wake up and be able to think and speak. It reduces recovery time, so muscle repair from injury. And obviously, it helped me big time. I wasn't injured, but man, I was hurting. And then it improves blood flow, tissue oxygenation that had to have been happening that day, because I literally felt like a new woman. The really unique thing is it enhances nutrient absorption. So anyone that is struggling with getting their nutrients, maybe you have gut issues or whatever, this is going to help. It's going to help those nutrients absorb into the cell. And then it also accelerates cellular regeneration. So hello, anti-aging. It's an all-in-one mat. So you don't waste your money on this mat and this PMF. And you just get the Align mat, and it literally does everything. It will change your life. I use mine every day now, every day. So you're going to go to myalignmat.com. So that's myalignmat.com. You're going to use the code Dr. Amy. I always give you guys a code because they give me a code. for $100 off. So going to save you boatloads of money. And again, you're going to thank me for this one too, because that's what I do. I find you really, really cool stuff and I try it and I bring you only the good stuff that works. This is a part 2 on all things progesterone with Carol Petersen, but these are your questions. So we had a boatload of questions come in after the first episode that Carol and I did together. We'll link to that in the show notes. If you didn't listen to that one on progesterone, go back and listen. So much great information, so many gems. Now, this Q&A will definitely not disappoint. Many of your questions that are, whether you asked them or not, that are ruminating in your head, Carol answers on this show. So dive in and enjoy and up-level your health with maybe some more progesterone. Oh, Carol, I'm so happy to have you back on the show for part 2. Just a big Q&A, all the questions that came in after we released your first episode all about progesterone. I've directed so many of my patients and listeners to, go listen to this episode because it was filled with information. We'll put a link to that episode in the show notes as well, so y'all can go back and listen to part 1. This is part 2, just all of the questions that came in based on our episode together. So if you're ready, I'm ready. We're just going to dive right in. Love it. Love it. And it's funny because as I was going through these questions, a lot of them are questions that I get from my patients as well. So this is going to be a beautiful resource for me to send people to listen to get their questions answered. Okay, here we go. First one. Is Carol familiar with using detox supplements for estrogen dominance based off of estrogen pathways on a Dutch test? When and what do you use to detox excess estrogen from the different pathways, or just use progesterone or both?
Okay, well, that's quite a complex question. On the Dutch test, they warn about the consequences of 4-hydroxyestrone and 16-alpha-hydroxyestrone as being dangerous when you have too much of this. And they probably are. Maybe there's some truth in that. They're super stimulatory. Maybe one is supposed to cause DNA damage. I don't think we know all of that yet, but this is my perspective. 4-hydroxyestrone builds up when it doesn't get methylated. That's the next step. So I would look for other signs of low methylation, like homocysteine in the serum, or maybe you've had some genetic SNPs for your methylation genes, so you're a slow methylator. In that case, you need to help methylate, and that's methylated B vitamins or betaine hydrochloride, phosphatidylcholine, SAMe, all provide methyl groups. So you can metabolize your estrogen better to the methylate form, which is safe. So then the 16-alpha-hydroxyestrone, this just tickles me because the next step for that is iodine and thyroid is needed. So it's a glaring reminder to look at the thyroid function. And so people are using the Dutch test. Dutch is saying, oh, give some DIM, which is really not solving the underlying problem. So I like to dig a little deeper, see what's going on with the individual. So I'd look for other signs and maybe ask for a whole thyroid panel. And now we're in your bailiwick. So yeah. If I happen to see that, I like serum testing, and I can see those things with testing for thyroid. I can see testing for homocysteine. I can see that in that modality, plus many more analytes, which is why I like it. You get a lot more to look at.
Yeah, keep going with that. And then I have another question for you.
Did I miss any part of that question?
No. So would you use progesterone for an estrogen dominant state? I guess whether we're seeing this in a Dutch test and they're pushing down we'll call them bad pathways, or if we're seeing it in serum where there's a boatload of estradiol, maybe even total estrogen, and then progesterone, as we know, will come in at a 0.5 or a 1.3 or something really low like that.
Yes. So my position is, let's use progesterone. Let's use progesterone to eliminate the symptoms. And this is what I started thinking way back when we were treating young women for PMS at very, very high doses. I thought, well, we need so much because maybe we're so high with the estrogen. And we probably should start thinking about what we can be doing to bring both of those down. So you don't need quite as much progesterone. And let's look at how you can diminish that abnormally high estrogen. In the last 30 years, back then we knew nothing about estrogen metabolism. In the last 30 years, we learned a lot more how to manage that better. And that's the tactic I would take. I'd like to see women comfortable first, and then we have time to dig deeper to find the reasons why that estrogen is so high.
And do you even go by the Dutch test when you're looking at the progesterone levels on a Dutch? Is that even remotely accurate for detecting the amount of progesterone in a woman's body?
No, even Dutch themselves say it's not accurate for those using creams, that you're not going to see it. And this is peculiar with progesterone creams and serum too. It's not raising the serum very well. One paper I saw said if you wanted to use a progesterone cream and see a rise in the serum, you've got to pull your blood sample within an hour after your last dose. After that, it dissipates all over the body, so you can't find it in the serum anymore. Consequently, some people propose that if they don't see it in the serum 6, 8, 12 hours later after your progesterone cream dose, it didn't change your levels and therefore it's useless. Oh no, you can feel the results right away. You can make a difference, especially in the mood and the sleep. You get really quickly reactions to it. It's working. Believe me, it's working. A serum level is not your whole body level.
Right. Yeah, I'm with you there. I mean, sometimes you're just treating on symptoms like we talked about in the last episode and not necessarily chasing a lab value.
Right. Which will get you nowhere.
Which will get you nowhere or down the path where you're still suffering. Okay, this is a big one that comes up a lot. How do you address progesterone intolerance, especially when used every method, orally, vaginally, transdermally, but you still want to, she still wants to take estrogen. She still has a uterus, but she's saying, and I sometimes I wish these people were here so we could expand on this, but she's saying that she does not tolerate, we don't know what that means, oral, vaginal, or transdermal progesterone.
Yes, it sounds very much to me like she's been playing around with small doses much too small for her need for progesterone. So in that lower range, which I think is actually quite dangerous to be playing around for some when the progesterone need is really great, a little progesterone will be intolerable. Every estrogen symptoms, sore breasts, headache, anger, rage, panic attacks, can be provoked by a dose of progesterone, which is too small. And when women do this, they become convinced it's not the dosage form, it's the amount of progesterone that you've used. Back to Katerina Dalton, her starting dose for severe PMS, 400, 600 milligrams suppositories multiple times per day. And then we give women 100 milligram capsule and they think they should be okay. No, it's not going to happen.
Right.
They can have trouble. Not everybody, if you're aging gently, it'll be fine. But so many of us are coming to this point in our lives with some serious issues, and the deficiency's been building up for decades. So it's become a real problem.
Now, what about those women that they can't tolerate oral because of it changing over to too much allopregnanolone, if I have that correctly, in the liver, but they can tolerate the transdermal or the vaginal? What's going on there?
So way back when I was working at Women's International, it was years and years before we even became aware that some women were having this problem. And about that time, somebody published a paper, 10 women given them progesterone, I forget which dose, only one drowsy out of the 10. And they did check allopregnanolone levels and determined it was the allo that was causing all the drowsiness. So there's this, it doesn't happen to everybody. And our recommendations then were to change the dosage form. I did an experiment myself. I have some progesterone capsules. I was gifted with a whole bunch of capsules. So I don't mind 100 milligrams, doesn't bother me, 150. So one morning I took 250 milligrams. And I was totally whacked out. My trainer came over and said, what's wrong with you, Carol? You're drunk. I just, and I said, it's from the progesterone. I said, we have to work out, but we've got to be careful because I do feel dizzy. And then right after he left, I had a big breakfast, lots of protein, lots of fat, like some eggs, and it was gone. So I think that I was able to metabolize that away. And so then I want to bring up the point, it might be dose related. So maybe at 100 milligrams at a time, you'll have that, but maybe if you had 200, 300 milligrams at a time oral, it might be a problem. So sometimes maybe splitting up your dose. And one more thing I could add, Geraldine Pryor, when I was asking her about this, she thinks that women have been so sleep deprived that they actually have a sleep deficit going on. And until your body catches up with its sleep, you may have this grogginess and dizziness from progesterone.
Okay.
But I have heard it occur in some women with cream. Not often, again, not often.
Yeah, not as often with cream. Well, what I will hear with the oral is that some women will have the opposite effect of what progesterone is supposed to do. So instead of being calm, they'll be amped up and agitated. Instead of having better sleep, they'll have insomnia. But that just seems to be just with the oral. And then when you change them over to a cream base, they're fine.
And it could be relative to what they've been able to use from the various dosage forms. Now we talk about how many milligrams of progesterone being used, but each dosage form has different absorption patterns and different totals. David Zava once told me that when women use creams, the amount absorbed from a particular cream could be as little as 10% or as high as 80%.
Okay. Right.
So,
and we talked about that on the last podcast too. If you're hypothyroid, you might have issues absorbing the cream.
Right. Or if you're old.
Yep. Or not applying the cream properly or applying it over like oils. I mean, there's so many. Yeah.
Yeah. Your skin simply doesn't have the absorption capacities it used to do. And we think that's true with vitamin D too. As we're aging, they're saying our ability to make vitamin D in our skin from the sun diminishes as we age. So it may be also we have trouble using it through our skin as we're more aged. But I don't know.
Yeah.
So making a PhD on that.
Honestly, that could be a whole, that could be a whole cohort study. Okay. This next question really hits home for me because I bitch so much about people using the term functional, using the term integrative, or even just doing hormone replacement therapy, and they don't have a freaking clue what they're doing. So here we go. What about progesterone for postmenopausal, post-ovarian cancer, Hashimoto patient? My HRT person says it's useless since I had a hysterectomy.
Oh,
yeah.
Okay. All of this comes from this pharma project, and they worked through North American Menopause Society. They've worked through the Endocrine Society, and they worked from the American College of Obstetrics and Gynecologists, and they produce position papers, and they say exactly that: no uterus, no progesterone. Like, what other hormone in your body goes to one spot? It's like incredulous. When somebody tells me their practitioner says that, I say, will you get back to your practitioner, ask them if they failed physiology? And because of simply that, this is crazy. And that a person even says something like that, they've been propagandized. So they don't have a knowledge base. They're doing what they're told. And it's very lucrative to withhold progesterone from a postmenopausal hysterectorized woman. It's progesterone would be helping sleep, anxiety. So they're on sleep aids, antidepressants, benzodiazepines, hypertensive drugs because adrenaline's out of control, drugs for migraine. It's a cash cow. So somewhere, I think that it probably was done deliberately. If we leave these women like they are, we'll get a lot more traction out of these last decades of life where we can pile them full of drugs.
Mhm.
It's a horror show, but every cell in your body needs progesterone, likely. And progesterone is made independently from the organs. That's another thing. There's a whole intracrinology. That means the hormones are made inside cells. They're made inside the Schwann cells for the nervous system tissue. They're made independently in our brain from cholesterol. They're made in the mast cells to balance the estrogen there so you don't dump histamine. And there's probably still more I haven't learned yet.
Well, yeah, and it's anti-proliferative. So it's literally helping protect you against cancer. And I mean, can we go so far as to say, well, Big Pharma knows that if you get cancer, they're making millions off of you because that is a big money-making disease. Big time.
That's right. And just like the endometrial cancer getting worse with fewer progesterone receptors, as the receptors are atrophying, it means you don't have enough progesterone. So your body just lets them go fallow. And so the question is, why would you let those receptors downregulate when you know it's a cancer worse? Why don't you just feed those receptors and see if you can overturn that cancer? I bet you can most of the time.
Yep, absolutely. So this kind of blends into the next question regarding uterine polyps. So can progesterone actually prohibit or eliminate uterine polyp formation?
And I put it in the same kind of category with fibroids, et cetera. They're probably stimulated by excess estrogen to progesterone. Also, I'd look for a thyroid and iodine component anytime you have weird growing things, cysts and fibroids. A cautionary note with some of these things, if you're in that low dangerous zone where you're making your estrogen even more potent with the low doses of progesterone, you're at a point where you could be making these growing things grow. So you've really got to leap right up there and take a good dose to prevent that from happening.
And about how long would somebody, let's say they have a uterine polyp, how long would it take for that woman to see, I guess, a retest where there's no longer a polyp?
I don't think you can predict. I would expect it would take some months.
Mm-hmm. Yeah.
But maybe check on it every 6 months or so. But
Yeah.
with time, you should see diminishment and improvement. If you've balanced the estrogen, you've stopped the growth potential, so everything calms down.
Okay. Beautiful. Now, what about cycling progesterone? So we have someone that is postmenopausal, hasn't had a cycle period in years. Should they still cycle or take time off from their progesterone?
Okay, so I have to refer everybody to Susan Wiley's book, which I know you like that therapy, and it's really an extremely well-referenced book when you get down into it. So should we try to recreate our body in a younger fashion? And consequently, the doses that are used with the Wiley protocol tend to be a little higher than the average practitioner who is using hormones. I have no problem with that. I don't know that we actually know where optimum levels are. And there's a range here. You can be comfortable, but not optimal. So I'd like to see optimal for everybody. Does this include cycling? I think it's a personal choice. When your ovaries stop ovulating, you're not really ovulating, and there's no ovulation going on. It's just mimicking the cycle. So is that a point that it was the ovulation that was the most important thing, and even cycling to mimic it doesn't give you everything back? I think that's probably true. Ray Peat once said, a postmenopausal woman should look like a pre-menarche young girl.
Oh,
Just and that's where the adrenals and sex hormones should be, just before the cycling starts.
okay. So, and this is a question I get a ton from my patients. They love their progesterone so much. They're postmenopausal. And do they have to even just take one day off per week does that break do something to the progesterone receptor sites as well as the estrogen receptor sites?
Well, I've never seen any proof of this at all. Where I think this whole concept comes from is from the FDA approval of Premarin way back when. Their first approval was vasomotor symptoms. But in practice, what was happening, as I saw over the years, a lot of doctors would say stuff like, oh, use your Premarin 5 days of the week, stop 2 days, use it 3 weeks per month, stop, all kinds of these starts and stops. But Premarin as synthetic hormones don't get metabolized, used to metabolize like bioidentical hormones. They've identified 60 some hormones in there, they're all molecules that are cholesterol-like in shape. And some of them are estrogenic, some of them are more progesterone-like, some of them are more testosterone-like, but not being human equivalent, they're going to accumulate. So the idea, which they recognized, was, oh, these things are piling up. Let's give the body a short break. Bioidentical hormones are used quickly and excreted. They're not piling up. So I don't see a reason for, let's have a drug holiday. You'll suffer for it.
Well, you've made many women happy right now by saying that they can stay on their progesterone, so that way they will sleep all the time, all 30 to 31 days of the month instead of just 24
And again,
of them.
Your ovaries provide a cyclic amount of progesterone, but your adrenals don't. That's steady throughout. So you really can consider menopause adrenal pause, because when the ovarian function ceases, we're very dependent on our adrenal function to keep us symptom free. So when you hit the wall, it's the adrenals haven't been able to cope with the loss of the ovarian function.
Well, and then can't we also say that because the adrenals can steal progesterone to make cortisol, when we're in that adrenopause state, we need more progesterone for that stress support.
Right.
Yeah.
And your adrenals are making progesterone too. So it is an adrenal hormone and hydrocortisone. And then you have all these metabolites. We talk about, people question about storing hormones, and there really aren't depots in your body where hormones are stored. And an action at a receptor is like a millisecond. It's not sitting there hanging around unless you block it with something, not with its normal procedures. And so thinking that you have this reservoir of bioidentical hormones somehow in your body, or you have estrogen stuck in your tissues. No, that's not really happening unless it is stuck because you can't metabolize it. And we're not measuring these. We don't measure synthetic hormones that we can't metabolize, but they can be floating around there in the bloodstream because your liver can't get rid of it. So we're not really storing, but what we do have, if you have adequate hormones like cortisol and all of its many metabolites, and we have progesterone metabolites too. We talked about one. We need to be looking at that more. We've been looking at estrogen metabolites a bit, but there's a lot more to be known. So I believe some of the reservoir is in the metabolites. When you have a big stress, you start sucking up a lot of cortisol, or hydrocortisone is the same. You're going to be sucking up the reservoir of whatever progesterone is available, whatever the metabolites of cortisol is available. It'll all go to deal with the stress.
Yeah, absolutely. So the progesterone is actually helping us deal. It's supporting your adrenal glands, essentially.
Right.
Yeah. So this is something crazy that I learned about electrolytes that I did not know before. Low sodium diets, when you cut back on your salt, can actually contribute to insulin resistance. So number one, we don't want that. We know that is going to definitely increase our weight. Low potassium status suppresses your growth hormone, your anti-aging hormone. And that even just having low thyroid function disrupts your electrolyte excretion. So, if your magnesium is low, we know that that's going to interfere with thyroid T4 to T3 conversion. Now you have this whole electrolyte excretion issues that you're pushing out more electrolytes, but you need to keep them in for that conversion. I'm telling you, the data is crazy on the importance of electrolytes. So I use the OG of electrolyte powders, Element. Number one, because they taste absolutely freaking amazing. I want to use probably too many packets in a day, quite honestly, because I keep putting them in my water because they taste that good. But of course, I also know that I'm getting my balance of electrolytes. And in the summer, I need more. Hey, even in the winter, when I'm skiing and snowboarding, I'm sweating that all out. You need more. So if you want to try some of these amazing, just amazing electrolytes and actually feel the difference, I mean, you will feel the difference. You'll feel more energized. You won't cramp up and you will get better sleep with this as well. I'm telling you, definitely better sleep. Go to drinklmnt.com. So spell out drink, DRINK, LMNT.com/thyroid. And this is going to save you some money. You can get the sample box. You can try all the different flavors. My absolute favorite, just side note, grapefruit and orange. drinklmnt.com/thyroid. Okay, estrogen kickback and how to overcome it. This is from a patient of mine. And we talked about it one morning. And she's like, you know what? I want you to ask Carol this. I said, okay. So she wants to know, what is this estrogen kickback and how do you overcome it if it's real when you start taking progesterone and increasing the dose of progesterone? She said, I'd also love to know if there is a dose of progesterone that is considered to be too high.
Okay, so the estrogen kickback is a term that I think started at the estrogen dominance support group on Facebook. I think that's the etiology.
Okay.
Anyway, they were recognizing, and I did a podcast with them early on, and that's exactly what they're experiencing. The low doses of progesterone were making them feel worse. And so I went on and said, you have to have enough progesterone to overcome that. So they started calling it the kickback phenomenon. You get more estrogen activity when you're already loaded with estrogen activity.
Okay.
So that's kind of nice. I've seen it described in the medical literature. Recently, they called it progesterone inversion, allopregnanolone inversion instead of a Gaussian curve like this for absorption. It goes the other direction. It's flipped. So the high doses get you relief and the low doses get you misery.
Okay.
So I called it biphasic. One thing I wrote to a researcher who didn't answer me yet, I'm going to have to go after him, because it has a dual nature at the low doses and the high doses. So that's important to recognize, and you need to get yourself at a dose higher so all the estrogen excess and the kickback symptoms are gone. And it's a real shame. A lot of women might get prescribed some progesterone and their doctors say, oh, I'll see you in 3 months.
Yeah.
And put themselves 3 months of torture. They're doing their best. And that's really not good for that patient. It's very bad for their body to keep them in this hyper. Now you've exacerbated the problem with the low dose of progesterone. You shouldn't stay there. Get out of there.
Get out of that low dose state. Well, I'm actually thinking back to, I might have shared this on our last podcast. I forget my experience with oral estrogen in my 30s. Now, I had PCOS and I couldn't even tell you what dose I was given of oral compounded progesterone. And my thought is, now hearing you speak right now, my thought is the reason why I gained weight, which they were like, no, that can't happen. That's impossible. I'm like, no, I gained 10 pounds like in 2 weeks. I'm thinking that because I was already in an estrogen dominant progesterone deficiency state with PCOS, that low dose, most likely, of progesterone that they gave me was so low that it basically made me estrogen dominant.
Yep.
Yeah.
Even worse.
Yeah.
Even worse. And then there's the question of, can you use too much progesterone? So in my mind, you have to get beyond the amount of progesterone that is in the third trimester of pregnancy, which it's impossible to get to those levels when you never we never can. I've seen some labs now going from 50 to 550 nanograms per deciliter during a pregnancy. If you were to load yourself up on, well, progesterone capsules, let's say, we did have a letter from a doctor doing fertility work with 600 milligrams oral capsules, divided doses. He got up to 40, 30, 20 to 30 is considered really good luteal. We hardly ever see that.
Right. Yeah. Yeah.
You can swim in that. And that, I say that goes for men too. The male fetus was exposed to huge amounts of progesterone and did not hurt him a bit. And then on top of this, men are really being tortured by lack of progesterone too. They're being given a drug called finasteride. If you look at Wikipedia, which has one good thing they have is they put structures. If you look at the structure for finasteride, and you look at the progesterone structure, they're practically the same. But we choose to give men a drug that has caused suicide and loss of sexual interest and loss of sexual function. And that's okay, but we have to be afraid of progesterone. That's really scary.
Yeah, no, I agree with you. I totally agree with you. So is there, piggybacking on that answer, is there a minimal level of progesterone that we want to see at day 19 to 22? I mean, I would think, no, there's no minimal. We don't want you minimal.
The only reason for testing there is to find out if somebody's ovulated or not. So for example, today I talked to a woman, she was in that window, her progesterone was 1.9. And I said, so I can conclude from that number that you didn't ovulate that month. So your progesterone that you should have a nice big wave of was simply not there for you. That's what those numbers can tell you.
Now, if you're testing a woman who is postmenopausal, you just test any day then. I mean, there's no way to tell, when a certain, but that woman's hormones are still fluctuating throughout the month. We just don't know where she is in that fluctuation.
Right. Well, there's some natural fluctuation all the time. That's another danger of getting a number from a lab. 5 minutes later, it could be something else if you checked it again.
True.
So then you make a big clinical decision on it, and it's totally wrong. Like what percentage of the time you spend this high or this high might be a better indicator, but we can't measure that. No, postmenopausal, I don't see a reason for initial testing. You know that progesterone's down, testosterone's down, estrogen's down. Yeah. So start building accordingly, restoring the hormones, getting rid of the symptoms. Then if you want to recheck, like one thing to recheck is like, what if they had a lot of estrogen hanging around? Like I say, you can get somebody pretty comfortable with lots of progesterone, but it's because they've got a lot of estrogen hanging on. So then you may make a decision to work on this estrogen piece.
Yeah, no, exactly. And it always comes back to asking that patient how they feel. Like, how do you feel? Because we can look at a number all day long, but if you're like, well, I'm still anxious, I'm not sleeping, having hot flashes, let's do some progesterone. Exactly. Now, there's been some controversy in our world with a very well-known, big name doctor that's come out lately with some pretty crazy stuff around hormones and is starting to discredit himself. But regardless, Miss Sandy here brings in this question. Dr. Mercola claims topical progesterone converts into something unusable, and the best way to take it is transmucosal, massaged into the gums and a vitamin E base. Which way is best?
What he actually said in that article was that progesterone in a cream converted to allopregnanolone irrevocably. It wouldn't go backwards. And that might be true. It actually might be true. But that's what you want it. Allo is much more potent at the GABA receptor than progesterone is. Also, it may be that his transmucosal form does the same thing. He offered no proof that it did. I talked to Dr. Frank Nort at Rhine Lab after that. I said, could we be measuring allo? He said it's not really worth it because it doesn't show up very much in the urine. So it's already been converted yet to something else. So we can't get a handle on it. I thought it'd be cool too. You could test people for this, how drowsy you're going to be if you could have a couple test doses and check your urine,
Yeah.
but not going to work.
Okay. So, but there's nothing wrong with transdermal progesterone.
No,
Okay.
not at all. And really, transmucosal is also a skin-like thing. It's a little bit different in secretions, but you are still like theoretically transdermal. So he's telling you one transdermal doesn't work, the other one does.
Yeah, I was thinking that too. I mean, it's still kind of a crapshoot, basically. If you're rubbing it on your gums, you don't know if maybe you produce excess saliva. Maybe there's something in your saliva that counteracts. I mean, we don't know. Are
And then
you rubbing it in the right way?
Yeah, you swallow a bunch and it's oral. You really can't tell. But I will say there seems to be better absorption transmucosally, either in the mouth or the vaginal rectal area. When women do have problems with absorption, sometimes it helps to switch to that.
Now, on that note, are there any risks or even benefits to taking progesterone vaginally, or she says rectally, which I've never heard of that way of delivery, but vaginally versus taking it orally or using a cream? Or is it just really more kind of individualized per each woman, each person?
It's individualized, and you can get better absorption vaginally and rectally. So for those who are having trouble with absorption in the creams or the oral, it's an alternative that might work.
Okay. Yeah. So if they're not feeling better, I'm not going to say if we don't see the number climb, because we can't rely on that.
Yeah.
If that person is not feeling a change, an improvement in symptoms, then maybe change the delivery method.
Mhm.
Okay.
Yep.
Okay. Now, why is it that we do not use estrogen, at least if you're being treated properly? Let me say that. Do not use estrogen alone or unopposed, meaning you have to have progesterone on board. Why is that? Can you expand on that?
Okay, the activity is so intertwined, but it doesn't even make sense. The biggest amount of sex hormones that your body makes is progesterone. Secondly, it's testosterone. Estrogen's at the very bottom. Yet we've, like, in our medical culture, we made it like the most important thing. And it isn't. You don't do well without the progesterone support. The estrogen doesn't work as well. Postmenopausally, I used to see women getting loaded up on estrogen, trying vainly to get relief from hot flashes and anxiety and stuff, and just using more and more estrogen. Their doctors and no relief. The higher they go, it's still the problem. I even met a woman she would steal Premarin from the pharmacist counter. It used to be a fast mover, and she'd just grab it because she needed to load up in her mind.
Yeah.
to get some relief. Well, maybe she did. There are circumstances that this can happen. We've given estrogen too much importance in the scheme of things. And it doesn't really drop in most women till menopause.
Mm-hmm.
And what's happening in the peri years, which is not in most of the medical literature, but Jerry Lynn Pryor published this, we have the highest estrogens of our whole lifetime. So you're taking a high estrogen time of life, telling you we'll give you some estrogen to solve your progesterone deficiency symptoms. It's craziness going on. And this high estrogen is saying, oh, you need to protect your bones. This again comes from Ray Peat, but and I don't have his references. He said high estrogen increases parathyroid hormone. High estrogen, low thyroid situation, it's usually the same thing. And you can actually prolactin, did I say parathyroid? Prolactin, high prolactin levels, unless there's a tumor, it's from this imbalance of hormones, and it will come down with progesterone. If you leave yourself with high prolactin, then parathyroid hormone goes up and sucks calcium from your bones, increases the calcium in your bloodstream. So this theoretical, you need estrogen for your bones, estrogen only, you're actually making more people osteoporotic with the estrogen only. So I think it's a very dangerous situation.
Well, on that note, I just saw another post unrelated to our progesterone talk today from a woman whose friend has really high prolactin levels. And of course, we didn't get all the labs or anything like that. She does have Hashimoto's, her thyroid is a little bit whacked out. But the high prolactin, they're giving her cabergoline, if I'm saying that correctly.
Bromocriptine. Bromocriptine.
Okay, bromocriptine.
Yeah.
To lower the prolactin. But what I'm hearing, and you can correct me if I'm wrong, is that maybe they should use progesterone instead of the medication to lower the, right?
Yeah. And every once in a while you get somebody with, they get nipple leakage in their older age. You should check prolactin then, because it's probably gotten elevated, giving you signals to produce secretions from your breasts. That occurs with every now and then, so that should be checked out. But prolactin will come down with progesterone. Also, it's a component of some cancers. Prolactin gets way high. Prostate cancer, for sure. I heard a lecture on, and I even asked this is one from a cancer clinic in Germany, and I went to him afterwards because he suggested bromocriptine, and I said, why not progesterone for the prolactin? He goes, well, that would work too. Yeah. That was the end of it. But just recently I saw a video he did later, and he recommended progesterone. So I guess.
Well, good job on schooling him on that, even though he totally stole your thunder, but that's all right.
Yeah.
At least it's changed his tune, because that's what we need docs to do. Just change it up a little bit. Give progesterone, not antidepressants.
Yes.
Okay, on the topic of birth control, I was going to actually say give progesterone instead of birth control as well. Now, okay, we walk a fine line if you're 16, 17, 20, and you really don't want to have children, and you're sexually active. Like I get birth control in those years. But after that, when I hear a 30-something-year-old taking birth control, I'm like, how about just be an adult? And, get off the thing that is killing you and destroying your thyroid and pumping your body full of synthetic hormones, and let's just be an adult. So what is your take on birth control versus progesterone? And is it even possible, let's say for that younger cohort, to use bioidentical progesterone instead of birth control pills for the purpose of birth control?
Or you mean progesterone, like for the purpose of like PMS symptoms?
Well, I'm going to get to that in a second, but I mean like literal birth control, because isn't birth control essentially progestin?
Yes, and an estrogen most of the time, unless it's the mini pill progestin only. But there's a couple pieces there. One is we did have young women still have progesterone deficiency symptoms while on the birth control pill. Not surprising. We tried to see if we could relieve it with adding progesterone. Very resistant, which is not surprising because you have everything blocked. There's another thing that happens with birth control pill use, and this is a hugely abnormal increase in sex hormone binding globulin, off the charts. Like I think the normal goes up to 70, it'll be 300, 400. What does that mean in practicality? It means you're shutting down your testosterone effectiveness and your estrogen effectiveness by that birth control pill. And on top of that, as far as we've been able to check out, and it's not been decades, it's not even probably been years, it's not coming down very fast. So you're resistant, and now you've got this built-in resistance to therapy. I still think use it. One of the common side effects of birth control pills is dyspareunia, painful entrance to the vaginal tissue. So it's different tissue than the vaginal tissue itself. It's more like your urinary tract and bladder tissue, and it's full of testosterone receptors. So that birth control pill wipes out your testosterone so much that this area is so tender. Women say they can't have sex with their partners anymore because they can't stand the pain. That tissue is dying for testosterone, which you should use and use it directly there for some relief, and get off the birth control pills. But now we're putting older women yet. There's a woman, Susan Diadamus. She's a Pulitzer Prize winner from New York Times. She wrote a weekend magazine on menopause because she found that she was underperforming. She couldn't remember things as well. Energy was low. And so she does this big whole magazine story. She goes to Columbia University, NYU, Mount Sinai, all the big teaching hospitals and stuff, and finds out that you really don't get good advice for treating menopause in these big centers. And
Right.
after doing this, the article closes with she decided to go on birth control pills. And one of the really alarming things she wrote about in that article was that the teaching hospitals are teaching the young doctors to ignore women with symptoms of hormone deficiency because they don't think they can do anything about it.
Oh, wow.
So we're having, don't go to a young doctor because
Right.
you think
We know what
doctors
they're learning.
say
And then,
badly before, now they're going to be at zero. It was shocking, and it's equally shocking to me because I know a lot of practitioners in New York City use bioidentical hormones. There's a rich culture there for using them, and she didn't tap into that at all. So that was very sad.
yeah. Oh my gosh. That's so sad. And it just speaks volumes to what we're seeing in conventional medicine these days. I mean, it's great if you need something fixed, you broke something.
Mhm.
Absolutely. Conventional medicine is there for you to fix you and mend you up and sew you back together. But when it comes to prevention or even just feeling good, just quality of life, that interest is not there in conventional medicine. It's just not. It's not. So moving on to what you brought up earlier, how to use bioidentical progesterone for a 16-year-old with heavy cycles that actually cause anemia.
Okay, that 16-year-old has low adrenal progesterone 2 going on. That's when that buildup is occurring. And so if there's not enough progesterone supplied by your adrenals, that layer is going to get thicker and thicker. So when ovulation occurs, she gets some progesterone that helps her get rid of it. But she doesn't have enough progesterone at the first part of next cycle to keep that layer down. So it just needs to use maybe a couple 100 milligrams of progesterone in the follicular phase and then increase at the luteal phase to enough progesterone. There are no PMS symptoms, no pain, no headache, no water retention, no moodiness.
Yeah, go figure.
You can
All
get
of
rid
those symptoms that we were told that you just deal with it because it's part of being
all of that. And
pregnant.
it's so easy to deal with that heavy bleeding. This also occurs very often in perimenopause, and conventional medicine lets you go ahead and bleed till you beg for a hysterectomy. A little bit of progesterone in the first part of the cycle, the adrenal progesterone, will stop that overgrowth of the endometrium.
Mm-hmm. Absolutely. So, okay, that leads into really not so much the last question, but the last comment that you and I were talking about before we jumped on, and that I'll share with my audience because you've been helping me so much with this. So, some people know that I've been using the Wiley protocol. I was not bleeding, therefore I got a uterine biopsy. That biopsy showed complex atypical hyperplasia, which I'm being told by conventional medicine can turn into, you have a 30 to 40% risk of that turning into uterine cancer. And then, of course, they scare the bejesus out of you, saying it can go in the fallopian tubes and then the ovaries, and then you have ovarian cancer and all of this. And oh my God, just get your uterus ripped out. So, and my comment to you prior to the show, and this is not to offend any woman that chose this, but when I looked into the side effects that come or the potential complications that can come with a hysterectomy, oh my God. Basically everything can just fall out because like you said, Carol, your uterus is holding everything up in there. So when they say prolapse, they basically mean all your shit is just going to fall out. That's a nice way of saying it. Then on top of that, they're telling me, well, you got a 10% chance of possibly like nicking your bladder. And if your bladder is adhered to your abdominal wall, which my whole spine is curved because of my scoliosis. So my rib cage is twisted. So I'm like, my organs aren't even in the normal place where organs are. And they're going to go in there and start clipping away things and take stuff out. It just didn't sit well with me. So I consulted with you, and your advice that we are trying right now is to significantly increase progesterone. My purpose in telling everyone this, and I will keep you all updated on the progress and what happens next and this and that. Number one, to be your own patient advocate and actually think through some things, and don't just buy into what conventional medicine is telling you to do if they want to take out body part or an organ. And then number two is, I want you, Carol, to speak to the women that get hysterectomy. I can't understand why anyone would choose this with the complications that can happen, but they're just really in that state of not having any other answers because their doctors aren't giving them the option of progesterone.
Yeah, so they're getting desperate, and the main cause of hysterectomy is that heavy bleeding. 600 to 700,000 hysterectomies are occurring in the US every year. The majority of those are from heavy bleeding, and it easily fixed, but they won't fix it. They won't tell you, and they might not even know, because that information's been withheld from your practitioner too.
Yeah.
They're not traveling in the circles you and I travel.
Right.
They never hear it. So that's why you do have to advocate, and really with the loveliness of the internet and podcasts and Zoom, that a lot more information is getting out there. And I always say, you don't have to give me credence for what I say. You don't have to believe me. You have to think about your options. When you at least talk to me, I know you're open and looking for answers. And if I don't say anything that resonates with you, don't do it. It's not your pathway. It might be something else entirely. So this thing with hysterectomies is it's just out of the zone, ethical or whatever. I also read just recently that the rate of cesarean births in the US is like astronomical. It used to be emergency only, and now it's scheduled. And it's something like, I don't know, 50-60% of US babies born by cesarean section. Why are women just letting themselves get cut up?
Yeah.
It's terrible. You have all kinds of post cesarean problems with improper nervous system conduction across scars and whatnot. It's a terrible choice. And yet we're like assembly line, the doctor doesn't want to wait for the birthing to start and wants to schedule it on such and such a day in the calendar. This is totally atrocious. Progesterone is so effective to prevent that heavy bleeding. Also, it's so effective if you use enough and early enough, that fibroid issue might go down. Sometimes the fibroid gets so big, it's like crowding your bladder or something. It's a problem.
Mm-hmm.
But if you know to treat it early, which the doctor is, we'll watch it.
Yeah. Watch and wait.
Watch and wait till it gets large enough. Or endometriosis is another thing we have a lot of surgery for. And this is a tricky deal. There's probably overgrowth of yeast involved in endometriosis.
Mm-hmm.
So there's this underlying problem that really needs to be treated. And sometimes they just do surgery and scrape off the excess tissue that's sensitive to estrogen, but they don't really give you a resolution why this got started and what you can do to prevent it again. So you'll see women say, they had such pain from endometriosis that surgery was the best thing they ever did. But there's also women who had the surgery. It didn't stop the endometrial tissue from going all over inside their perineum, and they're still in pain. Now you have no organ and still pain. So you haven't gone to the primary problem. What's causing this?
Mm-hmm.
And we find I wrote a blog once called Flowchart Medicine. That's how we're being taught. If this, then that.
Yeah. Yeah.
And that's the way you're supposed to, as a practitioner, practice. But you're never supposed to question why the if is occurring in the first place? How did you get here? What caused that? Can we eliminate the causes? And we have so many things causing endocrine disruption these days. Our food supply, they're poisoning our skies and our water from the COVID injections. They've already been publishing like intense number of miscarriages. There's a paper published about how progesterone, if you've got a long COVID situation, progesterone's gone, hydrocortisone is gone.
Yep.
It had such a critical effect on your endocrine system. And who's looking there? You go to doctors and they look everywhere but the hormones. I don't know. It should be like a blood chemistry. It should have a hormone profile.
I agree. I totally agree. And yeah, progesterone is coming in with those long haulers and COVID vaccine injuries to calm down the nervous system. And you mentioned that on the last podcast, how that adrenaline surge can be calmed, whether it's a case of AFib or tachycardia, or just that nervous system overload, kind of tying back to what we said earlier with support of the adrenals. Progesterone can come in and just calm that down.
Right. And so necessary. I think we're a hyper adrenal world right now. We're sympathetic dominant. One of the things I wondered is if somebody's wearing a Oura ring or one of those watches that give you information whether you're parasympathetic or sympathetic. If you could monitor the effect of your progesterone, if you started sympathetic and it flipped you. I have no good answers on that, but I have a theory it might.
Yeah. All the listeners with an Oura ring. I want you to do an experiment and report back.
Feedback, yeah.
I like it though. I like it. Oh, I love this, Carol. I mean, I could sit here all day and just converse with you about all things hormones. Can we bring you back for just an all hormone podcast too?
Oh, I would be delighted. People think I'm lopsided.
You're lopsided. Well, I mean, progesterone. You've taught, and I mentioned this in the last podcast, I mean, you've really elevated the knowledge of some top level docs in this field. So, and you've definitely taught me. So that's why I think we pull you in on the progesterone piece, because you've changed our way of thinking and dosing progesterone so much that we're like, oh my gosh, let's talk to Carol. But no, we absolutely will bring you back for an all hormone podcast for sure. But this has been just so much fun, and I've learned so much. And like I said, I've changed the way I treat men and women with progesterone now.
Oh, it's you'll be just amazed. I had a woman over in Europe. She had an appointment, signed up for some coaching, and she gets on. She said, "I've seen your podcast with Dr. Amy." She said, "I was on 200 milligrams of progesterone. I immediately doubled it." She goes, "I felt so much better." She goes, "I think I'm an 800 milligram. I want to double it again."
Maybe she is.
Maybe she is. I know, and it was so delightful to hear that. And so she's got some other underlying problems I can give her some guidance with, but it's an essential building block to start from there. When you've got that settled in, gives you stability, and you know what to do. You know how to handle the crises in your lives, or missing meals, or eating bad food. Progesterone gives you some cushion, and now you know how to give a little more when these things happen.
Yes, absolutely. I love it. I absolutely love it. So we're going to bring you back, but can you tell people where they can find you in the meantime? And I know a couple of my listeners and my patients are actually doing a 15-minute consult with you just to kind of review where they're at with their progesterone. I told them, well, just tell me what she wants to do. We'll raise your progesterone. That's cool. So tell people where they can find you.
Okay. It's the wellnessbydesignproject.com. And YouTube too. Will be on YouTube when you post it. I post it to my YouTube channel, but it's at the Wellness by Design Project.
Beautiful. Beautiful. Yeah, we'll give you the recording and whatnot to put on your YouTube channel, but I'm super happy you have one, because that's just a plethora of information where people can just binge listen. So I'm happy. Carol, I love you to death. Thank you so much for your time and your knowledge and your.
My pleasure.
Yeah, it's beyond appreciated. Beyond appreciated.